Hi, my name is Michael Ivan. I'm one of the brain tumor and skull-based surgeons here at the University of Miami, and I'm excited to give the Connectome of the week. This is a case of mine of an elderly gentleman who had a recurrent glioblastoma. It's IDH wild type, MGMT negative. He had already undergone a surgery about a year earlier and now has progression of disease and was becoming aphasic with his symptoms. Otherwise, mentally, he was doing quite well. And so the concern was during surgery, we would obviously do this case awake and map out his speech function, but because he was already having some difficulty with talking preoperatively, we weren't sure if we were going to be able to map it out to the right extent and the right detail that really deserved to be done in this case. Typically in this case, I try to pretreat the patients with Decadron and mannitol, really optimize the brain swelling. But now that we have Quicktome, we actually could see the tractography and the connections that are in the brain and look specifically at the language corridor, but additionally look at the visual corridors and the sensory motor cortex and the networks. And so what we have here is the preoperative MRI. You can see this is a large cystic temporal insular glioma with a significant amount of edema. And preoperatively he was able to get through about 70% of his speech. And what we wanted to really understand here is, even though this came to the surface on the temporal lobe, was really what was the extent of where Wernicke's would be, where Broca's would be, and where the connections of the uncinate fasciculus would be on the back of the tumor, because it went so deep here. Also where motor and visual cortex would be. And so by using the Quicktome, we could quickly see that this overhanging temporal lobe brain here on the left, which was right underneath the vena labbae, was eloquent tissue. And there really wasn't much of a resection that we could do safely on the back here. So using the cyst wall on the posterior aspect of the tumor was going to become critical. However, all the anterior temporal lobe was somewhat silent or non-functional, and therefore was a safe area to take. As we look around, we could see on the bottom of the tumor, this is actually some of the visual tracts inferiorly going back to the occipital lobe, and they were clear from the tumor, and we know already where the motor tracts were. And so superiorly on the top of the tumor, we could see where Broca's were, where Broca's area was and his speech area, and then also where the fibers connecting the speech areas going around the tumor would be. And so this really helped us outline and reassure ourselves that we can resect the tumor, everything anterior to the tumor, but deep and posteriorly we need really respect the boundary of the cyst and use that area. And so we were able to then take the patient to the surgery. We were able to do an awake procedure, and he was able to tolerate this really well. And what happened was that the awake findings and the awake mapping during surgery coincided very nicely to the findings of the Quicktome before the operation. Again, once reassuring ourselves that this overlying temporal lobe of the overlying cyst was in fact an area of Wernicke's and was very critical to his speech center. We were able to get a safe maximal resection, greater than 95%, and the patient did well. He had 1 or 2 days of some very mild speech issues, but then resolved quite quickly, and to the time of discharge, he was actually back to his neurological baseline. So knowing this going into surgery was just very reassuring for the patient and the surgeon to understand the risks, understand the anatomy, go through the case with him and the family, and really set the expectations of what the surgery would be. One of the unique things about Quicktome is not only can we see the different tracts and areas of eloquence in 2 dimensionals, but also in 3 dimensions, which really helps us as with these complex tumors and the complex anatomy, understand the approach angles and what we could actually expect to see during surgery. So in this case, we have the 3-dimensional MRI here. We could see here that this is the front and the back, and here's the temporal lobe here where the temporal tumor is, diving into the temporal stem and going into the posterior insula, deep underneath here the uncinate and the connecting fibers of language. We have here Broca's area and speech, and then we have here a more receptive speech area of Wernicke's. And we could see as we scroll through, how close these tracks really come to some of the areas of the tumor. And what's interesting is now we can very quickly add some of the other eloquent tracts around this area to add more information. So if we want to add the sensory motor cortex above, we could see here again where it is on top of the tumor and where the superior boundary may be. And if we add the visual system below here, we could kind of scroll around and look in a different area of the tumor where exactly the visual system would be on the inferior aspect of the ventricle and the cyst on the posterior aspect of the tumor. And you can see clearly as you begin to put all these pieces together where the most logical area of approach angle and the safest area of the tumor would be, and where we're going to need to be extra critical with our awake mapping technology. So just to summarize, here we have the preoperative MRI, axial, coronal, and sagittal, and we could see the different areas of the tumor. And again, we use the Quicktome to basically come in through the anterior temporal lobe, remove the anterior temporal lobe, and then a posterior trajectory. And you can see here a postoperative film shows that there was a good resection of this tumor with very minimal enhancement remaining. And that was all because we were able to both do the awake motor mapping and speech mapping, as well as have the idea of where the connections would be with Quicktome. Thanks so much for watching this episode. It's really my honor to be a part of this. Thank you.